Hello, today we have a lecture about the treatment tuberculosis and leptospirosis. Mycobacteria intrinsically resistant to most antibacterial drugs. Because they grow more slowly than other bacteria, antibiotics that are most active against rapidly growing cells, reliably ineffective. Mycobacterial cells can also be dormant and thus completely resistant to many drugs or killed only very slow. Mycobacterial species, intracellular pathogens and organisms residing within macrophages, inaccessible to drugs and penetrate these cells poorly. Combination of two or more drugs required to overcome the obstacles and to prevent emergence of resistance during the course of therapy. The first line drugs used in the treatment of tuberculosis are isoniazid, rifampicin, ethambutol, pyrazinamide. The second line drugs used for tuberculosis infection. When first line drugs have been discontinued owing to resistance or side effects, there are capreamicin, cycloserine, new macrolides, for example, clarithromycin and azithromycin, and quinolones, for example, ciprofloxacin. To reduce the emergence of resistance organism, compound drug therapy is used to treat tuberculosis, involving in initial phase designated to reduce the bacterial population as quickly as possible and prevent emergence of drug resistance. Lasts about 2 months and consists of 3 drugs: isoniazid, rifampicin, and pyrazinamide. Ethambutol is added where there may be resistance to isoniazid. For example, those who have previously been treated for tuberculosis or immunocompromised. Continuation phase of 4 months consisting of 2 drugs, isoniazid and rifampicin. Longer treatment regimes may be needed for patients with meningitis or bone involvement. You can see a slide with information about drugs of first line. And next slide, information about the second line drugs. Isoniazid, rifampin, or other name rifampicin, rifamycin, pyrazinamide, ethambutol, and streptomycin. These are the 5 first-line agents for treatment of tuberculosis. Isoniazid and rifampin, most active drugs. Isoniazid rifampin combination administered for 9 months with cure 98% of cases of tuberculosis caused by susceptible strains. Addition of pyrazinamide to isoniazid rifampin combination for the first 2 months allows the total duration of the therapy to be reduced to 6 months without loss of efficacy. In practice, therapy initiated with a 4-drug regime of isoniazid, rifampin, pyrazinamide, plus ethambutol or streptomycin until susceptibility of the clinical isolate has been determined. Isoniazid is the most active drug for the treatment of tuberculosis cases by susceptible strains. Isoniazid penetrated into macrophages and active agents both extracellular and intracellular organisms. Mechanism action isoniazid inhibits synthesis of mycolic acids, which essential components of Mycobacterial cell walls. Isoniazid is a prodrug that's activated by CATG, the Mycobacterial catalase peroxidase. Pharmacokinetics. Isoniazid is readily absorbed from the gastrointestinal tract, 300 milligram oral dose, 5 milligram per kilogram in children. Achieves peak plasma concentration of 3 to 5 microgram per milliliter within 1 or 2 hours. Isoniazid diffuses readily into all body fluids and tissues. The concentration in the central nervous system and cerebrospinal fluid ranges between 20% and 100% of simultaneous serum concentration. Metabolism of isoniazid, especially acetylation by liver and acetyltransferase, is genetically determined. Isoniazid metabolized small amount of uncharged drug excreted mainly in the urine. The typical dosage of isoniazid is 5 milligram by kilogram per day. A typical adult dose is 300 milligram given once daily. Pyroxidine, 25 to 50 milligram per day, is recommended for those with conditions predisposing to neuropathy and side effect of isoniazid. Isoniazid is usually given by mouth, but can be given parenterally in the some dosage. Incidence and severity of untoward reaction to isoniazid are related to dosage and duration of administration. And first, immunologic reaction, fever and skin rashes, occasionally seen. Drug-induced systemic lupus erythematosus can be reported. Next, direct toxicity isoniazid-induced hepatitis is the most common mild toxic effect. The risk of hepatitis is greater in individuals with alcohol dependence and possibility during pregnancy and the postpartum period. Development of isoniazid hepatitis contraindicated further use of the drug. Peripheral neuropathy is more likely to occur in slow acetylators and patients with predisposing conditions such as malnutrition, alcoholism, AIDS, diabetes mellitus, and uremia. Neuropathy is due to relative pyroxidine deficiency. Isoniazid promotes excretion of pyridoxine, and this toxicity is readily reversed by administration of pyridoxine in a dosage as low as 10 milligram per day. Central nervous system toxicity, which is less common, includes memory loss, psychosis, and seizures. These effects may also respond to pyroxidine. Miscellaneous other reactions include hematologic abnormalities, provocation of pyridoxine deficiency anemia, tinnitus, and gastrointestinal discomfort. Isoniazid can reduce the metabolism of phenytoin, increasing its blood level and toxicity. Next drug, rifampin. It's a semisynthetic derivative of rifamycin, antibiotic produced by Streptomycin mediterranea. It's active in vitro agents gram-positive and gram-negative cocci, some enteric bacteria, mycobacteria, and chlamydia. There is no cross-resistance to other classes of antimicrobial drugs, but there is cross-resistance to other rifamycin derivative, for example, rifabutin, rifapentin, mechanism of action. Rifampin binds to the beta subunit of bacterial DNA-dependent RNA polymerase, and therapy inhibits RNA synthesis. Resistance results from any one of several possible point mutation in the gene for the beta subunit of RNA polymerase. This mutation results in reduced binding of rifampin to RNA polymerase. Human RNA polymerase doesn't bind rifampin and isn't inhibited by it. Rifampin is bactericidal for mycobacteria. It readily penetrates most tissues and penetrates into phagocyte cells. It can kill organisms that are poorly accessible to many other drugs, such as intracellular organisms and those sequestrated in abscesses and lung cavities. Rifampin is well absorbed after oral administration and excreted mainly through the liver into bile. It then undergoes enterohepatic recirculation with the bulk excreted as deacetylate metabolite in feces and a small amount excreted in the urine. The drug is reliably highly protein bound. Clinical uses. First, so it's mycobacterial infection. Rifampin usually 600 milligram per day. It's 10 milligram in kilogram per day orally, must be administered with isoniazid or other anti-tuberculosis drugs to patients with active tuberculosis to prevent emergence of drug-resistant mycobacteria. And next, as indication, rifampin has other uses in bacterial infection. In round dosage of 600 milligram twice daily for 2 days can eliminate meningococcal carriage. Rifampin combined with a second agent is used to eradicate staphylococcal carriage. Rifampin combination therapy is also indicated for treatment of serious staphylococcal infections such as osteomyelitis and prostatic valve endocarditis. Side effects. Rifampin imparts harmless orange color to urine, sweet tears, soft contact lenses may be permanently stained. Occasional adverse effects included rash, thrombocytopenia, and nephritis. Rifampin may cause cholestatic jaundice and occasionally hepatitis, and it commonly causes light chain proteinuria. If administered less often than twice weekly, rifampin may cause a flu-like syndrome characterized by fever, chills, myalgias, thrombocytopenia, and anemia. Its use has been associated with acute tubular necrosis. Mm-hmm. Co-administration of rifampin results in significantly lower serum levels of those drugs. Next drug, etambutol, inhibits Mycobacterial arabinosyl transferase, which encoded by the EMB-CAB operon. Etambutol is well absorbed from the gut. About 20% of the drug excreted in feces and 50% in urine in unchanged form. Etambutol is always given in combination with other anti-tuberculosis drugs, and side effect hypersensitivity to etambutol is rare. The most common serious adverse event is retrobulbar nephritis, resulting in loss of visual acuity and red-green color bleedness. Pyrazinamide is relative of nicotinamide. It's stable and slightly soluble in water. Pyrazinamide is well absorbed from the gastrointestinal tract and widely distributed in body tissues, including inflamed meninges. The half-life is 8 to 11 hours. The parent compound is metabolized by the liver, but metabolized renally cleared. Pyrazinamide is important frontline drug used in conjunction with isoniazid and rifampin in short course, 6 months regimes, sterilizing agent active against residual intracellular organism that may cause relapse. Streptomycin. The typical ideal dose is 1 gram per day. It's 15 milligram per kilogram per day. Streptomycin penetrates into cells poorly and active mainly against extracellular tubercular bacilli. Streptomycin crosses the blood-brain barrier and achieves therapeutic concentration with inflamed meninges. And clinical use, it's tuberculosis. Streptomycin sulfate is used when injectable drug is needed or desirable, and in the treatment of infection resistant to other drugs. Other drugs always given in combination to prevent emergence of resistance. Side effects of streptomycin is ototoxic and nephrotoxic. Vertigo and hearing loss are the most common side effects and may be permanent. Toxicity is dose-related and the risk is increased in the elderly. As with all aminoglycosides, the dose must be adjusted according to renal function. Toxicity can be reduced by limiting therapy to no more than 6 months wherever possible. Alternative drugs listed below are usually considered only in case of resistance to first-line agent, in case of failure of clinical response to conventional therapy, and in case of serious treatment, limiting adverse drug reactions. Ethionamide is chemically related to the niacid and similarly blocks the synthesis of mycolic acids. It's poorly water-soluble and available only in oral form. It's metabolized by the liver. Cerebrospinal fluid concentration equal to those in serum. Ethionamide is administered initially dose of 250 milligram once daily, so 1 gram per day dosage. Those theoretically desirable is poorly tolerated because of the intense gastric irritation and neurologic symptoms that commonly occur. Ethionamide is also hepatotoxic. Neurologic symptoms may be alleviated by pyroxidine. There can be low-level cross-resistance between the niacid and ethionamide. Capreomycin. It's peptide protein synthesis inhibitor antibacterial obtained from Streptomyces capreolus. Capreomycin is nephrotoxic and ototoxic. Side effect: tinnitus, deafness, vestibular disturbance occur. The injection causes significant local pain and sterile abscesses may occur. Dosing of capreomycin is the sum of that of streptomycin. Toxicity is reduced if 1 gram is given 2 or 3 times weekly after initial response has been achieved with daily dosing schedule. Cycloserine. Cycloserine is inhibitor of cell wall synthesis. The dosage of cycloserine in tuberculosis is 1 gram per day in 2 divided oral doses. Cycloserine is cleared renally. The most serious toxic effect, peripheral neuropathy and central nervous system dysfunction, including depression, and psychotic reactions. Pyridoxine dosage 150 milligram per day should be given with cycloserine because this ameliorates neurologic toxicity. Side effects, which are most common during the first 2 weeks of therapy, occur in quarter 25% or more of patients, especially at high doses. Aminosalicylic acid is folate synthesis antagonist that's active almost exclusively agent M tuberculosis. It's structurally similar to P-aminobenzoic acid, PABA, and to the sulfanilamide. Aminosalicylic acid is readily absorbed from the gastrointestinal tract. The drug is widely distributed in tissues and body fluids, except the cerebrospinal fluid. Aminosalicylic acid is rapidly excreted in the urine, in part as active aminosalicylic acid and in part as a chelated compound and other metabolic products. Very high concentration of aminosalicylic acid reached in the urine, which can result in crystalluria. Aminosalicylic acid is used infrequently because other oral drugs are better tolerated. Gastrointestinal symptoms common and may be diminished by giving the drug with meals and with antacids. peptic ulceration and hemorrhage may occur. Hypersensitivity reaction manifest by fever, joint pain, skin rash, hepatosplenomegalia, adenopatia, hepatitis, and granulocytopenia. Next drug, kanamycin has been used for treatment of tuberculosis caused by streptomycin-resistant strains, but availability of less toxic alternatives, for example, capreamycin and amikacin, there has rendered it obsolete. The role of amikacin in treatment of tuberculosis has increased with increasing incidence and prevalence of multi-drug resistant tuberculosis. And next, amikacin must be used in combination with at least one and preferably 2 or 3 other drugs to which the isolate is susceptible for treatment of drug resistance cases. Recommended dosage, the same as source for streptomycin. In addition to the activity agents, many gram-positive and gram-negative bacteria, ciprofloxacin, levofloxacin, moxifloxacin, and gatifloxacin inhibit strains of Mycobacteria tuberculosis at concentration less than 2 microgram per milliliter. There are also active agents, atypical Mycobacteria. Moxifloxacin is the most active agent Mycobacteria tuberculosis by weight in vitro. Levofloxacin tends to be slightly more active than ciprofloxacin agents Mycobacteria tuberculosis, whereas ciprofloxacin is slightly more active agents atypical Mycobacteria. Fluoroquinolones, important addition to the drugs available for tuberculosis, especially for strains that are resistant to first-line agents. Linezolid. It has been used in combination with other second and third-line drugs to treat patients with tuberculosis caused by multi-drug resistant strains. Conversion of sputum cultures to negative was associated with linezolid use in these cases, and some may have been good. Significant and at times treatment-limiting adverse effects, including bone marrow suppression and irreversible peripheral and optic neuropathy, have been reported with a prolonged course of therapy that are necessary for treatment of tuberculosis. Rifabutin is derived from rifamycin and is related to rifampin. Its activity is similar to that of rifampin, and cross-resistance with rifampin is virtually complete. Rifabutin is both substrate and inducer of cytochrome P enzymes. Because it's less potent inducer, rifabutin is indicated in place of rifampin for treatment of tuberculosis in patients with AIDS infection who are receiving antiretroviral therapy with protease inhibitor or with non-nucleoside reverse transcriptase inhibitors, for example, efavirenz. There are drugs that also cytochrome P substrates. The typical dosage of rifabutin is 300 milligram per day, unless the patient is receiving protease inhibitor, in which case the dosage should be reduced to 150 mg per day. It's also effective for preventive therapy of tuberculosis, either alone in 3 or 2 months regime or with pyrazinamide in 2 months regime. Rifampicin is analog of rifampin, as with all rifamycins is bacterial RNA polymerase inhibitor, and cross-resistance between rifampin and rifampicin is complete. Like rifampicin, potent inducer of cytochrome enzymes, and it has some drug interaction profile. Toxicity is similar to that of rifampicin. Rifampicin should not be used to treat patients with AIDS because of unacceptably high relapse rate with rifampicin resistance organisms. You can see short information on this slide. And last slide today about treatment leptospirosis. Tuberculosis leprosy is treated with dapsone and rifamycin for 6 months. Lepromatous leprosy is treated with dapsone, rifamycin, and clofazimine for up to 2 years. Dapsone resembles sulfonylamides chemically and may inhibit folate synthesis in a similar way. It's active orally, side effect numerous and some fatal. Clofazimine chemically complex dye that accumulated in macrophages, possibly action on mycobacterial DNA, as the clofazimine can discolor the skin and urine red. As a side effect on numerous, it's active orally. So it's all today. Thank you for your attention.